Good evening and welcome. Thank you so much for joining us this evening in our very first virtual O'Connor Chair Lecture. I'd like to take just a minute to recognize some folks who are with us tonight. Miss Amy Warner, who is the director of the O'Connor Foundation. It's through the generosity of the O'Connor Foundation that this evening's event is possible, and we thank you. Dr. Margaret Dragovich, Hartwick College President. Dr. Bill Eman, Hartwick College Provost. Karen McGrath, Vice President of Enrollment Management and Student Experience. Paula Lee Hobson, Vice President of College Advancement. Dr. Kelly Bean, Assistant Provost in Academic Affairs. Lisa Ianello, Director of Corporate, Foundation, and Government Relations. Sharon Dettenreiter, Professor Emeritus and former Department Chair. Distinguished guests, faculty chairs, faculty, staff, students. And finally, I would like to thank Nursing's Events and Community Committee for their hard work in putting this event together. I would like now to introduce Dr. Nicole Zhang. Dr. Zhang is an assistant professor in nursing at Hartwick College. She completed her PhD in nursing at Binghamton University. Dr. Zhang is a urology nurse expert with specific research interests, including urinary incontinence. She is currently working with the National Institutes of Health to better understand benign urologic conditions. She is also working on the development of a wearable bladder sensor for use in the management of urinary incontinence. Dr. Zhang was recently elected to the Society of Urologic Nurses and Associates Board of Directors and is a frequent contributor to the nursing journal, Evidence-Based Nursing. Dr. Zhang has a passion for advancing the discipline of nursing, and in this regard is working on the development of a nursing theory, the theory of empathy and mutual understanding. Related to COVID-19, Dr. Zhang is working on 2 research publications with the Center for Nursing at the Foundation of New York State Nurses, exploring the experiences of nurses during the pandemic. Her teaching focus is on community health nursing. She is the chair of Nursing Events and Community Committee and will be moderating this event. Dr. Zhang.
Hello, everyone, and Dr. Gruss, thank you for those welcoming words. As you all heard, I'm Dr. Nicole Zhang, and I'll be responsible for moderating this lecture today. I'm glad to welcome our panel, who will present on this timely topic. The aim of this lecture is to take a forward-focused look at the evolving nature of the COVID-19 pandemic from multiple perspectives. On this lecture panel today, we'll have representation from the public health perspective, from the disaster preparedness perspective, and from the mental health perspective. We in the nursing department believe that this will be an excellent experience for our campus and for the local community. Before we begin our formal presentation, I'd like to go over some of the logistics and outline of this lecture. I will introduce each speaker, and I'll give each speaker 10 to 15 minutes to complete their presentation. After each panelist's presentation, I'll make some culminating remarks and we'll proceed to the next presentation in the same fashion. After all 3 presentations are complete, we'll proceed to a question and answer segment. I'll pose the questions from the audience to the panel. All participants are voice muted and video muted, and the question and answer segment is expected and allotted about 30 minutes time in this lecture series. All questions should be posted in the Q&A section of this Zoom call, of this Zoom lecture. Please direct specific questions to either panelists or the panel at whole as it pertains to the question you ask. If you do not specify the directionality of the question, I'll just pose it to the whole panel. I do encourage you also utilize the chat function of this Zoom call for discussion. So now we'll begin our formal presentation. I'd like to welcome our first presenter, Chris Holmes. Chris graduated from Union College in 1986 and immediately embarked on his active duty military career with deployments to Germany, Uruguay, and Somalia. After 9 years of active duty, he transitioned to the U.S. Army Reserves and a civilian career with New York State, serving in the State Emergency Management Office as the Regional Director and Program Manager, and most recently as the Director of Emergency Management for the Office of Parks, Recreation, and Historic Preservation. Chris remained active in the reserves with deployment to Iraq in 2005 to 2006. From 2010 to 2011, Chris served with the U.S. Africa Command, assisting the development of disaster preparedness programs in Ghana, Senegal, Kenya, Tanzania, and assisted in developing and conducting preparedness exercises in Myanmar and Vietnam. He has collaborated with RPI on the development of debris management model programs and served on the Federal Emergency Management Agency's National Steering Committee for the Disaster Recovery Public Assistance Program. Please join me in welcoming our first presenter, Christopher Holmes.
Good evening, everyone. And as many of you sort of wonder how emergency management or disaster management fits in from a parks and an emergency infectious disease outbreak, you're probably wondering that. I was too at the beginning of this entire incident as it continues to evolve. Next slide, please. In emergency management, we basically jokingly refer to the 6 standard phases of disaster management. And actually, these phases really are kind of accurate and true. In phase 1, we have what we call wild enthusiasm. Folks are very excited about a new problem, challenged by what's going on. The energy levels are high, and there's a real feel that your organization can utilize the pieces and the plans and the things that you have readily available to you that you've been practicing with for years, that you'll be able to use that to defeat whatever the issue is that's coming your way. In phase 2, we start seeing sort of a growing disenchantment and beginning to start feeling some dread along with this, as we realize that the problems we're facing might not be exactly what we thought they were going to be. And we're beginning to realize that maybe the paradigms we've been using to either develop our responses or look further down the road and how do we plan for our recovery don't fit the particular model that we're going into. Sort of really begin to feel that there's a challenge here that may be bigger than what we know. Phase 3, we jokingly refer to as it's mass confusion, characterized by multiple meetings. And you have meetings to prepare for meetings. And this is, again, for any of the new emerging threats or massive impacts, whether it be an infectious disease or a massive disaster such as Sandy, the Oroville Dam that was going to break and flood in California, or the horrific wildfires that are going on. Your systems start becoming overwhelmed. Your plans are not really working as you expected them to work. Your integration has not been worked out yet as you try to bring new forces to bear. And you have just a tremendous amount of confusion. People begin their days at dark 30, as we used to say in the military, and you don't end your day until close to midnight or later. And the exhaustion kicks in, confusion ramps up, and you really have to figure a way to get a handle on it. Phase 4, again, a little bit tongue in cheek here. We talk about our search for the guilty. And the guilty is what went wrong? How did we go wrong? What is not working? Why isn't it working? And you start searching for specific problems that you can solve or specific reasons for problems. Not always the best thing to do in the middle of the response of an event, and probably not even during the recovery phase of the event. So we're sitting there trying to figure out what didn't work while we're trying to figure out what is working. Phase 5, as we refer to as persecution of the innocent. You may have great ideas, plans, personnel, procedures, or organizational structures in place that should really serve you fairly well and that have been maybe serving you better than you think. during the event, but you need to get rid of something, you need to cut something apart, or you feel you need to make a change and make it now. And that good, solid piece, organizational structure, or something that you were doing right, or people that you had in the right place might get sacrificed. So we have to kind of be aware of phase 5. And then phase 6 is what leads to some of the challenges going forward. Promotion of the non-participants. It's an old military phrase we used to use. The folks that got you through everything you need to do, and the organizational structures and the connections that you made are fungible. And you wind up having them move to new jobs, different organizations, retiring. The concept needs to be modified. You don't modify it, you just 86 it or shelve it. And what happens then once you've done that, you kind of have what we call a lesson lost, where you've got a lot of stuff that you've put in place, you've met your challenge, you've overcome the hurdles to your challenge, but now that institutional memory can go away very, very quickly. Next slide, please. So what do we need to do? We have to break the mold of our standard 6 phases of disaster management. And it's not easy to break the mold. It's not that hard to break the mold either. It requires a couple things that are fairly challenging, but if you can grasp them and bring your organization to understanding them and yourself as understanding them as well, you can be very effective. First thing, all organizations have much more capacity to provide direct support to whatever the incident is that you might think. We in Parks really didn't see that we thought we would have much role in emerging infectious disease. I mean, after all, we're parks. People enjoy coming to us. They like to come and see the lovely parks we have, go on hikes, participate, camp in our cabins, go on our lakes or rivers or streams, and we keep them and manage them for folks. What does that have to do with an emerging infectious disease? Well, as we found out, we had a lot of folks that could move things from one point of the state to the other. We had a lot of capacity to give people breathing room and space. And by keeping our parks and facilities open, we could provide a sense of normalcy when everything else was shutting down. So our staff worked really, really hard to make sure that no park was shut or closed. We actually had record attendance this year above and beyond what we'd seen in the last 2. The other piece where you have a lot more capacity than you think is you take a look at your resources and personnel, and you'll find you have people with a really diverse skill set from either prior experience in other jobs, whether it be other parts of your organization, with the military, other jobs they've held in different careers. But you'll find that you have a lot of folks that are volunteer firefighters that know how to organize under an incident command structure, and a bunch of different pieces and skill sets that you can bring to bear that you didn't even realize were out there. The biggest thing that you need to do is change your is the internal view of your primary mission is the key to unlocking this potential. You have to be able to look beyond. We're parks. We just welcome people to parks, and we go home at 5:30 in the evening when the sun goes down. That has to change, and you have to change why you're doing what you're doing and how you are looking at yourself within the new event that you find yourself merged into. The other piece that you need to understand and be able to work to break that mold is to expand your network beyond your discipline and well outside your organization and your comfort level. Believe me, I am not really comfortable talking with a bunch of folks with a lot of letters after their name, PhDs and doctors. I only have 2 letters after my name, BS. Everybody in government needs one of those. And I also have been told upon occasion that I'm NUG, not unusually gifted. So to be able to expand your network, to reach out, to make contacts with other folks from other disciplines, other organizations, and other walks of life are also crucial to you're being able to break the mold that you've set for yourself in your organization. Next slide, please. Other lessons that we've learned and that you have to think about as we move forward in this emerging infectious disease. Nature doesn't play by our rules. Old plans don't work. For those of us that have been around for a while, we remember SARS-CoV-1. We remember smallpox. We remember Ebola. We remember H1N1, H5N1, all the planning and pieces that we tried to put in place, use of the strategic national stockpile, and planning for how we were going to manage the distribution of supplies, the distribution of vaccines, and the containment of the spread of whatever the outbreaks were and wherever they were occurring. I can say that pieces of those plans have come into play upon occasion, but in many instances, we found that they were not well tailored or well suited to what we were doing. And we started fresh with what we're actually facing, which is pretty unknown in comparison to a lot of the other pieces that we've worked with and diseases that we certainly know a lot more about on how they behave and what they do. Next piece that you need to learn, management of almost any disaster is all about logistics. We like to say in the military that good generals talk tactics. It's really great to talk about what you need to do to take that hill and get your soldiers to the top. But great generals talk logistics. What do I need to get my guys to go forward? How can I move it from point A to point B to point C? How do I store it? How can I guarantee that I've got a supply system and a delivery system that doesn't just pull but pushes, and that we anticipate and move things to the right spots at the right times and get them to the people that need them? It's a really big challenge. It's something that a lot of folks don't realize, but that is one of the lessons we learned, and the state has done a tremendous job here of creating warehouses to provide coverage to different areas, taking a look, in-flight, in-progress review of where those warehouses are effective, where they're not as effective, consolidating, talking about what we're going to do next and looking forward. And that's the other piece that we're going to talk about moving forward. This is a marathon. It's not a sprint. And in so many instances in the disaster management community, we're used to the sprint. We're used to the fires. We're used to even earthquakes. As bad as the recovery is, they're short-term events. The immediate protection of life and safety is, generally speaking, that in this nation, we're great about providing for very rapidly. 20 days, 30 days, 60 days. Anytime you're going beyond 60 days, you're starting to get into an area of disaster management and emergency response for public safety protection that is pushing the envelope. When we start looking, excuse me, when we start looking at things that are going well beyond that 90-day, 120-day, 240, 365, what day is it? It's March 95th. It becomes very, very challenging. So you can't lose your focus, and you have to look at building a long-term team, because the cavalry is not coming right over the hill on things like this. It's challenging. It can be done. You just have to think long and have a group of people probably not engaged in the daily fray, but get some people to be your long-term thinkers, your long group thinkers. Build your team and provide your team the infrastructure they're going to need: communications, facilities, materials and supplies, and personnel, administrative personnel and staff that they're going to need to be able to go long for you. Next slide, please. As we move forward on this long-term journey, we are taking a look at some things internally to ourselves. And this, again, we're doing this in parks as well as many other organizations, but I would encourage everybody to do it, especially in long-term, long grinding events and incidents. We have to reevaluate the legacy of our core mission tasks. We might be carrying a load of stuff that we are working with and that is near and dear to our hearts, that's been part of what we do for many, many years. We have to take a look at and say, in the new environment and the length of time we think it's going to last, can I still carry on that good to do, nice to do feature, or do I have to change and let that go? Maybe not permanently, but at least for a while, and shelve that and figure a way that I can let that task go. Don't focus on it now because I can't afford to with the constrained resources that we have, and still manage the event that we are going through. The other path forward that we need to make sure we accomplish when we involve ourselves with these things, we have to formalize the changes to our organizational structures and procedures. Capture what's worked. Don't let it slide by because, geez, this has been great. We've done it fairly well, but we really, really need to capture that which has worked for us, document it, formalize it, make it part of what we're doing every day for the near future, mid-future, maybe even long-term, and reevaluate it periodically to see if it needs to be changed or altered, or that we can let that piece go as we need to. In other words, we have to be constantly evolving, and we have to do it relatively quickly. Next thing that we have to do, especially in this particular instance, for this particular incident, we're looking at anticipating the shift from testing and test sites and test centers, which is where Parks has been providing a lot of support and a lot of logistical support and leadership capacity of managing those sites. We're looking now going forward to the immunization side of the house. So if we've been able to test from these sites and get thousands of people through a site in any particular day, that would indicate there's probably a good site that we could go forward for the immunization process. Some of them might not be suitable, some of them may well be. So we need to start looking, and we are starting to look now at how would we change a testing site into an immunization site? What additional components need to be brought on board? When are we going to bring this on board? And how are we going to make a more seamless shift from the portion of figuring out where this is impacting us and how to try to contain it to we now have a prevention measure that we can put in place. How do we get that distributed and how are we effective at doing that? Next slide, please. That pretty much concludes my very, very brief portion of this evening for how we're looking at it from a parks perspective, from a state perspective. Semper Gumby means we're always flexible, and that is our motto in parks emergency management. We don't know if we can do it, but we're certainly going to bend ourselves into a pretzel to try to for you. And with that, folks, I'll turn it over to our next speaker.
Thank you, Chris, for providing that engaging presentation. It was so great to hear the disaster perspective on COVID-19. I'd like to re-emphasize the importance of demonstrating perseverance with the execution of a lot of the public health measures that we're instituting right now. And despite the difficulty of the task, I just wanted to say that we are playing the long game here with COVID-19. And our individual contributions can really make a significant impact. So in the words of Chris here, let's continue breaking the mold. Thank you again, Chris. I would like to remind the audience that you can place your questions in the Q&A section, and I'll return to them during our Q&A session at the end of all three presentations. So with that being said, I'm going to continue on and introduce our next speaker. Our next speaker is Maria MacPherson. Maria A. MacPherson nursing career began right here at Hartwick College with a Bachelor's of Science as a nursing major and spans the hospital and community-based programs with an emphasis on public health and 21 years with New York State Department of Health. As acting director for the 14-county Central New York Region Office of the New York State Department of Health, Ms. MacPherson and the regional office staff actively engage with regulated facilities, local health departments, and community-based partnerships to promote quality of care and population-based services across the lifespan. A Robert Wood Johnson Foundation Public Health Nurse Leader, actively involved in the New York State Action Coalition and the American Nurses Association of New York, Ms. MacPherson received the Upstate Medical University President's Award for Voluntary Faculty Service in 2017, and the Central New York Nurses Association Nursing Excellence Award in 2018. She earned her master's in public health through the University at Albany School of Public Health. Please join me in welcoming our esteemed alumna, Maria MacPherson.
Thank you very much, Nicole. I'm very happy to be here to talk with you tonight. If you go to the next slide, I want to cover three areas really quickly, really just briefly touch on this disease, COVID-19, talk about New York Pause and New York Forward, and then spend a few minutes talking about the considerations for nursing practice. Next slide. So COVID-19 is the disease that is caused by the virus, which is called SARS-CoV-2. We know this virus spreads by droplets. It's person-to-person transmission. We know the virus has been detected in blood and stool specimens. And we know it can be on contact surfaces and that people can be exposed to it by touching a contaminated surface and then their eyes, face, nose, mouth, etc. Next slide, please. We know that this disease started in China in Wuhan province. It was first identified as a pneumonia in December 2019, thus the COVID-19 associated with this. But the disease rapidly spread out of China into Europe, into the United States. And right now it is a worldwide pandemic, and there are many, many countries that have been experienced disease. And if you go to the World Health Organization, there's a dashboard there that would give you very specific numbers. Next slide, please. If we look at the United States, CDC is another excellent source for material. And this is really showing us the rates of disease across the country. The darkest blue are really the states with the highest disease. And what you're seeing there is the Dakotas on the Canadian border there. They have the highest rates up there, along with the state of Montana right now. And on the East Coast, we're fortunate now, the color is lighter and there's less disease in that area right now. Next slide, please. New York has not always been so lucky. In the beginning of February was when the president closed the borders, international borders. By March 1st, we were in a state of emergency in New York. And what you're really looking at here is the epidemiological curve of disease. The dark blue are the number of tests that were done per day, beginning in March and to current time. And this is actually from one of the governor's press releases. The yellow on the bottom are of those tests, how many are positive. And so our positivity rate is very low. And then what you're looking at on the orange curve really is, it's really the rate of the disease that we've been experiencing. And so you can see very clearly there how that disease for us really significantly spiked in March and April before it started to come down. And that's what we refer to as bending the curve. If you go to the next slide, please. There's a dashboard if you want to find out specifically what's happening in your county. And you'll see the numbers there on the left. Really, actually, the number of tests that we're doing per day are actually phenomenal. So where we might have started with doing less than 1,000 tests per day in March, we now have the capacity to do over 100,000 tests a day across the state. That is huge. And then the positivity rates are there, very high. Also, we track, obviously, hospitalizations and deaths. Unfortunately, we have experienced a fair number of deaths in New York State, over 25,000. And that's a very sad and devastating number for us. Next slide, please. So we're doing all this testing. What does that really mean? And what is tied to testing has to be the epidemiological investigations. In other words, the test is just the beginning. It identifies the positive case, okay? For all of those cases, remember, we want to limit the spread of disease. So we do what's called contact tracing, really interview the cases, try to figure out when they were contagious, who they were in touch with, who were those close contacts. So each case could identify one contact, two contacts. A single case could identify 100 contacts. And so then you can see how this disease begins to spread rather quickly. Cases, we know, are positive. They have been identified as having COVID, the disease, and or the virus. Definitely the virus. They may not be as ill, but cases have the ability to spread the disease to others. So cases are put into isolation. In other words, they're encouraged to go home, really required by law. They could be fined significantly. And for the contacts, those close contacts, those people are placed into quarantine for 14 days. And this has caused a lot of confusion and frustration for the average person. My husband was in quarantine as a result of travel, and he absolutely hated it. He was climbing the walls. But it is isolation and quarantine are two key tools that we use to limit the spread of disease. For anyone who is a case or a contact, we want to make sure that there's appropriate linkages to care. So that's all part of these epi investigations. Next slide, please. All of that information helps us to do what is referred to as bending the curve. And think of that curve at the state that I showed you. Next slide, please. We bent the curve by really, again, identifying those cases, the people who were ill, limiting the spread of the disease in two real ways, one through prevention measures, and then the other for the most appropriate treatment for those who were ill. And for prevention, you've heard these things. These are the social distancing. This is wear your mask, wash your hands, do not touch your face, don't go to work sick. Those are the common measures of prevention that we put out there into the public, and we do know that they work. For a hospital or healthcare environment, prevention is a little bit different. That's more the personal protective equipment, and we'll talk about that in a few minutes. But we did New York Pause help to limit the spread of the disease by doing the contact investigations, also by expanding capacity for treatment, expanding bed capacity, expanding the ability of the machines, the ventilators, the medications. Time allowed us to expand all of those pieces and to also do some of the research and identify what really worked, what was the best treatment in different scenarios, and also to more readily identify who was getting ill. We also know that we need to continue to protect the infrastructure, and that was all part of New York Pause. And you all as nurses are really an important part of the infrastructure, along with all of the other essential services people that just keep our lives going every single day. Okay, next slide, please. But we can't, my New York experience that I'm going to talk about really focused around testing and what I explained to you, and I'll show you in a few minutes some pictures of where we did testing. The epi investigations is another very important piece that our staff have been involved with. And then there's a lot of surveillance, technical assistance, support to facilities and to local health departments around what would be the best guidance for managing the disease, the experiences that they have at that given moment in time. Next slide, please. So we have had teams of testing, nurses mostly, some EMTs, go out and test in facilities. So I'm just going to flip through a couple of these pictures, but we actually went into facilities, tested the residents of all nursing homes and adult care facilities early on in this process. Next slide, please. We also did testing out into the community. So the picture on the left is actually a warehouse that was part of a farm, a large farm operation, and we needed to set up testing there. On the right, we're actually in a fire hall and another small community that needed testing. Next slide, please. This was grocery store testing. We did dried blood spot testing randomly in grocery stores. The community didn't know. We would just show up in a store. Of course, we worked out the logistics with the store before arriving. And then whoever happened to be in the store that day was offered an opportunity for testing. That information told us statewide where the disease was early on, when we could see it in New York City, but we weren't sure how much it had spread upstate. So this grocery store testing was significant in that information finding. Next slide, please. So, and we also did community testing in different communities that were at risk. So this was actually a community in Western New York, and you can see it was a beautiful sunny day. We actually set up with the help of the local health department. They helped with many of these sites in a neighborhood that they identified as being of concern. And actually we had people knocking on doors, posting flyers saying, come get your free test here today. And we tested a lot of people that way. Next slide, please. And again, in the community, we set up in a parking garage, we set up in a church. We really set up in the locations that we thought would reach the target audience that we were trying to reach. Next slide, please. And these were two other sites. Some of them may look familiar to you, but it was an armory and a church. Next slide, please. And you know, when you're outside and you're doing community testing, the weather and everything does not necessarily cooperate. So here we got rained out. Everything had to be packed up rather quickly because there was a thunderstorm moving in and we needed to close the site down. So you have to be flexible in all of that. Next slide, please. So from all of the experiences from early February through the summer, we did learn a lot of information. We learned that we can bend that curve. That requires the support of everybody in terms of not only prevention, but treatment and protecting the infrastructure. We also know that there's a lot more that we need to learn from this. We know more about how the disease spreads. It is respiratory, as I said. We have better treatment modalities, and we know that prevention can work. But we still have a lot of questions about antibodies and vaccine and all of that, and we're continuing to move forward with all of those pieces. Next slide, please. So New York Forward is going to continue to build on all of the previous efforts that we have done. Testing capacity will continue to increase across the state. We will continue to have different kinds of testing. In the beginning, there was only one. Now there's at least 2 or 3 different methods for testing, and we're going to continue to hear more about that. There is a lot of information out there on various dashboards, whether it be the World Health Organization, CDC, or New York State. There's school dashboards, county dashboards, a lot of information out there. And we really are trying to support the reopening of businesses and schools, because we cannot be in shutdown mode forever. We do not function well that way, but we need to be able to reopen in a safe way. There are new technologies, as I mentioned, out there for testing and treatment. And the big thing, as Chris mentioned, is the vaccination that is moving forward. And while we're looking forward to a COVID vaccine, I really encourage everyone to think about the flu vaccine, which is starting to be available now. Next slide, please. So for nursing practice, just very briefly, just to keep touching on this, next slide. We are nurses, and I want you to think about what action are you going to take. You are a content expert. You know more about disease and infection control than the average person. But if you don't have the information you need, seek it out. There are experts around you. There's a lot of good information out on the internet, but you need to find credible information. And as a reference back to preparedness, you need to know what your facility's plan is. What is the plan for your unit where you're working? What might your role be in that plan? If you were to roll out a COVID unit or if you're going to roll out a vaccination plan, what might your role be? You need to know that. And also, really, I encourage you to be a mentor to others and to also seek out a mentor, because we all need to continue to learn. If there's anything to be seen from this, it's that we have to continue to learn and be flexible. Next slide, please. We all have risk and protective factors. This is very much a public health model. Identify the risk factors, minimize them, and increase your protective factors. Okay, so it's a respiratory disease. How can we protect ourselves from that? Well, that really goes back to good PPE, being fit tested, wearing the appropriate type of mask for the situation that you're in. Increasing your protective factors are things like using the PPE, but it's also getting your flu vaccine, it's washing your hands, it's not going to work sick, it's doing the health screenings when you present to work. And what I really want you to also think about is your personal life and your professional life, because it all intersects. And how can you operate as a professional if you're not comfortable with what's going on in your personal life? So just think about those factors. Next slide, please. Infection control is a core component of nursing practice. Everything comes back to infection control. So you really need to know this, know it well. Putting the PPE on is the easy part. Taking it off without contaminating yourself and all of the people around you is the hard part. Learn how to do it right. Learn what is medical waste and what is the proper disposal of it. And be very comfortable with social distancing measures, both in and out of work. And I just want to emphasize here that oftentimes people, and I can cite numerous cases, are very good about wearing the right PPE. Then we go into the break room, everything comes off, we're eating, chatting, sharing food, having little mini parties, and that's where this disease is spreading. So we really need to be cognizant of how this disease spreads. It spreads very, very easily for some people and in those close environments. So personal hygiene, good hand washing, all becomes very, very important, as well as cleaning of the environment. And hospital cleaning is a little bit different than home cleaning, but Florence had it right. The environment is really, really important. Next slide, please. The other piece for nursing practice always is quality assurance and quality improvement. So we have the information. Did we do it right? Did we do the right things right? Think really about process and outcome measures. And did it work? Measure effectiveness. And if it's not working, change. We really need to identify what's working and what's not working. And do that feedback, have that debrief, talk about it, document it, figure out how we can do better. That's the only way we're going to continue to move forward with this disease. Next slide, please. And think again about what it is that you could do. There are lots of resources. As I mentioned, the future of nursing is a big thing out there. The New York State Action Coalition is one arm of that. I would encourage you to become involved on a professional level in whatever way you feel comfortable with different things. But this is their campaign, and this is being used with their permission. It's a new one. It's called Wear One, Share One, Spare One. And what they're really talking about is wearing a mask, but sharing the story about how that mask is protecting someone, and sparing that life that we are protecting. So it's just one thing to think of that we could all do that is relatively simple. Next slide, please. And that's really it. I want to thank you for this opportunity. There's my contact information. There's a lot more to be said on this topic, and we'll turn it over to the next speaker.
Thank you so much for that presentation. It's so important for us to see the public health perspective. I really think it's also important for us to see the current work the Department of Health is doing, as well as the government, and the actions that have been taken now and progressively into the future. So thank you again. I would like to remind the audience to please feel free to post your questions in the Q&A section. So now I'd like to introduce our final speaker. This will be Dr. Allison Holman, a PhD, FNP. She is a professor of nursing at the Sue and Bill Gross School of Nursing and Department of Psychological Sciences at the University of California, Irvine. Her research incorporates multiple methodologies, including national surveys, clinical studies, and laboratory studies to identify early predictors of long-term trauma-related mental and physical health ailments. She has studied national responses to the 9/11 terrorist attacks, the Boston Marathon bombings, the Orlando nightclub shooting, and hurricanes Harvey, Irma, and Michael. Her team started a prospective longitudinal study addressing responses to COVID-19 pandemic among a national sample of Americans in March 2020. Please join me in welcoming Dr. Allison Holman.
Good evening, everybody. And it's my pleasure to be here. Thank you for inviting me to join you tonight. I'm coming to you from California. It's not nighttime yet for us, but close. Anyway, if you could switch to the next slide, please. As a background, so you know a little bit about me, I worked in a PEDS ICU in my first job after nursing school. I became intrigued by what I saw in the intensive care unit. I was floored by the amount of trauma that I saw people experiencing, and I became very interested in that. And so I went back to school and got my PhD in health psychology. And I've now been studying for not quite 30 years, but 25, going on 30 years, how people cope with major life trauma, both at the individual and the collective level. So my work has incorporated traumas such as wildfires, which we've seen. In fact, my town was just hit by one this week. So we've seen wildfires, I've studied terrorism, I've studied hurricanes, and then came COVID. Next slide, please. So COVID-19 is an animal of a very different type. It's a collective trauma, but it's very different because, next slide, please. What we see with COVID-19 as a collective trauma is that it's an invisible threat. You don't know who's infected. You don't know if the person next to you is infected. You don't know if who around you is infected. And because it can be transmitted asymptomatically, it makes it even worse. So people having this invisible threat makes the threat itself more intense. It's also an ambiguous threat. Like, we don't know how bad it's going to get. Right now, it's looking like it's going to get pretty bad again. We've got over 9 million cases in America. We've had 90,000. Our daily positivity rate has gone through the roof recently. So, it's ambiguous. We're not 100% sure how bad it's going to get, and it can get much worse. We need to do some mitigation measures for sure. But also, COVID-19 has ushered in a period of time where the future is very uncertain, in part because of these other threats. The uncertainty about the future is we all had to shut down and go home and work from home, and we didn't know if our next day's plans were actually going to work out the way we thought they were. And so for a lot of people, the sense of time, I don't know if you've heard of it, but there's a COVID time warp that's occurring. And I actually, in my dissertation study, studied the concept of time perception and how trauma impacts your time perception. And COVID is an example, a perfect example of how our sense of time has been changed by the dynamics of this pandemic, this collective trauma. And it's really important. I'm sure so many of you have probably experienced Blur's Day, right? It's like, is it today Monday or Tuesday? Wait a minute, where am I? What day is it? This is natural. The other reason why COVID-19 is a unique form of collective trauma is because it has required us to socially distance ourselves from people. We aren't in the close physical proximity to people we know and love, or the people we work with. We're working on Zoom like I am now, and that makes things quite different. And we're used to connecting with friends and family, especially during hard times, difficult times. And so now is a particularly difficult time for people. And I might add that it's particularly difficult in addition because over the course of the past 3 to 4 years, the stress in America has been way on the rise for our national samples. So the levels of stress in the country have been going up, and this year is certainly no different from that. We've had a cascade of events occur in relation to the COVID pandemic. We have the pandemic, we have the economic downturn, we have people losing jobs, we have people being kicked out of their homes. The series of events, the cascading trauma, we have the assault, the death of George Floyd. The country is dealing with a very serious spate of collective traumas that are affecting people. And so the stress is really, right this time around is just unique. Next slide, please. So the question then becomes, how do you do research on this that can be policy relevant, that can actually help us understand how to build and develop policies that will be most effective in mitigating the threat of the pandemic? Well, the first thing that we do in our research is we focus on prospective study. That means that we identify at-risk samples before an event happens. So what we do is we use survey research companies that have a panel of people on whom they've collected pre-event data. So they have data about their mental health, their physical health, their attitudes, their beliefs, etc., that they have collected before an event hits. And then right after the event hits, we go out and we do surveys on them. We also do longitudinal work. Longitudinal work is really important when you're doing this kind of research because you need to know exactly how people respond immediately after an event, but also how they respond over time, because those repeated post-event assessments of well-being will tell you, is this a short-lived downturn in well-being? Is it a long-lived one? And then you can look at early responses and say, well, what are the predictors of that? The longitudinal is really important. The other thing we do, which helps with the issue of making policy, is that we use representative samples of the population under study. So for us, our population is the American population. So our samples come from nationally representative, probability-based, nationally representative panels. So we've used a variety of survey research companies that actually collect data It's a very labor-intensive process, but they have the current study that I'm going to be sharing with you today was done on the AmeriSpeak panel out of the NORC Research Center at the University of Chicago. And then the other issue that we need to take into account when doing this kind of research is that you need a comprehensive study. You need to really look at a comprehensive view, a broad view of what are the various issues, the risk factors, the protective factors, the various issues that might be involved in understanding how people are responding and how maybe we can help them in the aftermath of an event like this. And so what I'm trying to say with all of this is that doing small cross-sectional studies with non-representative samples, generally speaking, isn't all that helpful in terms of policy, mainly because there's a lot of uniquenesses to those studies that don't transfer into good policy. If you could please advance 2 slides. Thank you. So what we did was we collected data from a group, as I mentioned, the AmeriSpeak panel. And as you can see here, our sample had completed mental and physical health assessments in 2018 and 19. And then March 11th through 13th, we have the World Health Organization and then President Trump declaring national emergency, declaring pandemic and a national emergency. So from the AmeriSpeak panel, they took 11,000 people who were on their panel, and they are a representative sample of Americans, and we randomly assigned them to 3 different cohorts. So, and these cohorts were consecutive. They each ran for 10 days. So the first 10 days was from March 18th to 28th, and the second 10 days were the next 10 days and the next 10 days. So over the month, between March 18th and April 18th, we collected data from 6,514 individuals at 3 separate cohorts. So we saw over time some differences in those cohorts, but each of these cohorts is a representative sample of the American population. Next slide, please. What we saw, as we expected, we saw that over time, the cohorts, cohort 1, cohort 2, cohort 3, as you can see here, the acute stress response, which is like early post-traumatic stress symptoms, acute stress responses increased systematically across the 3 cohorts, and they significantly increased. The same was true of depression symptoms. So we saw depression symptoms go up across the 3 cohorts. Next slide, please. So then we ask the question when we do this work, we say, well, what are some of the things that help us understand? What are the predictors of these increases, or what are the factors associated with these higher levels of stress and depression? So what we looked at was we looked at media coverage. I do a lot of work on understanding the role of the media. I tell people don't overdo the media all the time. But basically our findings show that overall high acute stress, psychological distress, and poor functioning were associated with more exposure to COVID-19 media coverage, with more conflicting information. As you may recall, a lot of times we were getting a story here, but then a different story there, and then another story here. That was very confusing for people, and that was associated with higher levels of acute stress, distress, and poor functioning. We also saw that secondary stressors, like I was mentioning earlier, secondary stressors like a lost wage or a lost job or the need for childcare or not being able to get the supplies you need for your home or whatever. Those kinds of secondary stressors were one of the strongest predictors of this increase in acute stress and depression over those first 3 cohorts. And importantly, of course, as you might predict, prior mental health and physical health disorders. So people who had reported that they had a mental health disorder or a physical health disorder of some kind in the 2018-19 data collection, pre-COVID data collection, were at greater risk for experiencing higher levels of stress and depression symptoms. And then importantly, and this is a really important issue, being younger. The younger folks in our study were the ones who were more distressed. And some people wonder, why is that? Why is it the young people? Well, the younger people have a lot more years ahead of them. Older people may feel like, hey, I've lived my life. If this disease gets me, it gets me. So, but younger people don't have that same sense of how to deal with this. And so a future, and often have a future in mind for themselves, thinking about maybe they're going to go get a new job, or they're going to go to college, or they're going to go do this. So when your future starts to get sort of truncated, and you're starting to look at being at home working on Zoom only, and the things that you were hoping to be doing in your life aren't happening, that can be very distressing. And indeed, it has proven to be for our young people. Next slide, please. So what about essential healthcare workers and other essential workers? What we found was that healthcare professionals and other essential workers, we found healthcare workers had less acute stress than other essential workers, which is a really interesting phenomenon. They had better functioning than other essential workers. So when we say other essential workers, we're talking about people working in grocery stores, meatpacking plants, you know, those kinds of bare essentials, the PPE making people, all of that. Healthcare workers and other essential workers had similar levels of depression and worry, and both of them had very low levels of worry about the future. And females had more acute stress than males among the essential workers, including health professionals. Next slide, please. So there was, what I'd like to do is share with you some findings from a recent study that was conducted in New York, because you guys are back east. And this study was just published mid to late September in General Hospital Psychiatry. And they looked at a very large hospital system in New York City in April. And they looked at stress, depression, and anxiety among healthcare workers. And as you can see here, there's a step up where the highest levels of stress, depression, and anxiety are seen among nurses and advanced practice providers. And this is not to scare you guys, but to say this means it's time for you to polish and hone and strengthen all of your coping mechanisms as you get ready to go into practice, or as you're in practice, because it's really important to have some of those there to help protect you. So let's talk about, if you could go to the next slide, please, the sources of stress that we saw among healthcare workers. First, click again, please. Fear of taking COVID home to the family. That makes sense, right? Everybody was afraid of taking it home. Next. Health of the family and friends. So people were worrying about whether their family and friends would get sick. Next. A general lack of control, feeling the sense that you don't have control over this. Again, that goes back to what I was saying at the beginning. An invisible, ambiguous, and uncertain threat can make you feel like you don't have any control. And that's when you start to have that sense of the future kind of like dissipating. And that's a problem. Next. Lack of testing, which is what we saw early on. We saw that there was a real a paucity of testing being done. It's picked up, luckily. And one more, again, next. And lack of PPE. Many healthcare providers were being forced to work without the adequate PPE. All of these were sources of stress for them in April in New York City. Next slide, please. At the same time, I mentioned a couple moments ago that healthcare workers actually were doing better than other essential workers. And I want to talk a little bit about coping and resilience, because there's several things that I think are actually quite beneficial to helping to promote resilience. And one of the things that I think has helped to allow the healthcare workers in our study do better than other essential workers is that they had a greater sense of meaning and purpose. I mean, you're in there, you're actually saving lives. You're actually doing the things that really need to be done to help your fellow citizens. And there's a tremendous reward that can come with that. Another aspect of coping and resilience that's important for healthcare, that may be important for healthcare workers, is physical exercise. These are the things that the individuals in this study said. Another was faith-based practice or spirituality. These are things that people, when people turn to their faith to help them, guide them, and give them a sense of calm. Individual or group therapy, yoga, online clinical support groups. A lot of hospitals have started those to help protect their hospital employees. It's been a good thing to see. Next slide, please. So what are our future plans for our study? Because as I mentioned, we're doing a prospective longitudinal study. So we've just finished collecting our second wave of data. And one of our future plans is to look at positive benefits from dealing with the pandemic. And what I'd like to do is ask you to reflect for just a moment on positive benefits you may have noticed, if any, from the COVID-19 pandemic. If there's anything that you've drawn from this that may be construed by you as a positive benefit, something that's come out of it. I want to encourage you to think about that and maybe try to share that with somebody you know and love. And sometimes it's good to try to make yourself get that perspective of what might be a silver lining in all of this for me or in this situation. That doesn't mean we don't realize and recognize the danger and the sadness that's all around in terms of the pandemic, but it may help us feel like, regain a little strength to keep moving on. Next slide, please. So other future plans, we're going to be reassessing physician-diagnosed mental and physical health in spring of 2021. And as we do that, once we do that, we're going to be doing some studies of the racial, ethnic, and socioeconomic disparities that we're seeing in early responses to the pandemic and link them to the subsequent physical health outcomes. I don't know if you're familiar with this, but worrying is actually bad for your heart. There is a good body of evidence that's developed that shows that there's a term that's used for it, perseverative cognition. So when we worry about things all the time and keep thinking about it, that can actually keep your cardiovascular system at sort of an alert kind of level and keep your autonomic nervous system running, sympathetic nervous system in particular. And so it's important to be able to try to dampen that down. And one of the things that we see is that when people are worrying over time, that may actually contribute to physical health problems down the road, which is why we're going to be looking at some of these potential risk factors and health over time. And then we're going to examine perceptions of the future. As I mentioned, the future has changed for everybody. We're all kind of in a place of not being as sure as we were. I was very certain about what was going to happen a year from now. Well, I'm not anymore. A lot of us aren't. So we're going to look at the perceptions of the future and how they're associated with both mental and physical health over time. Next slide, please. So conclusions. So what I would like to convey to you today is that media is, I mentioned the media earlier as one of the strong predictors of acute stress and depression. Media is a double-edged sword. We need it for information. We need to go to it to get information. But rumors and misinformation and disinformation are rampant on social media, and they're not vetted for accuracy. And so I encourage you, stop yourself before you jump into some clickbait that you see or anything, because you need to know, is that accurate information before you pass it on? And also overexposure to the media can be problematic. It can actually amplify distress, and that can have downstream health effects because it gets you worrying. Like I was talking about earlier, worrying is associated with poor health outcomes. And then conflicting political agendas and conflicting information are especially stressful, as we saw in our study. That conflicting information really causes a tremendous amount of distress because people don't know what's true, what's not true, who to believe, what should I do, how do I protect myself? And when you have an invisible, ambiguous, and uncertain threat, that is very, very dangerous. That can be very, very dangerous because it leaves people wanting. And then understanding, as I mentioned earlier, the cascading secondary stressors like job loss, wage loss, loss of healthcare, they matter a lot. And they have contributed tremendously to the stress that the country is feeling. And so we're going to be able to know, we literally just finished our second wave of data collection last Friday. And so we're going to be starting our data analysis and trying to get some more work done on that. Next slide, please. So I wanted to leave you with, this is from the National Institute of Mental Health. These are some suggestions that they give for how to protect yourself with COVID-19, again, to buffer yourself from the negative impact of COVID-19. So I want to encourage you to think about these and try to take them into account, really practice them, make yourself practice them, set for yourself goals that you can use to actively engage in these things. How are you going to take care of your body? How are you going to make sure you have time to kind of just chill and relax? What are you going to do to connect with others that you love, etc.? Next slide, please. And then I want to say thanks to my collaborators at the University of California, Irvine, and Mike Dennis and others from the AmeriSpeak panel, and the National Science Foundation, because they paid for this study. Thank you very much. And if you could flip to the next slide, this is my stress relief for you. To counter the impact of looking at media that can be distressing, reporters actually use pictures of puppies and kittens. I happen to really like puppies. I have a new puppy in the backyard right now, and I just wanted to put some cute puppies up there for you to look at to help de-stress. Thank you very much.
Dr. Holman, thank you for your presentation. I think it's really great to take this perspective on mental health and viewing COVID-19, as you said, as a collective trauma and the stressors and all the effects around that. That's a really important perspective for everyone to take as we consider the mental health and well-being going forward. So thank you for that presentation. So I'd like to begin by just thanking everyone on the panel for your presentations. They were great and excellent. And so now we're going to proceed into our question and answer session. I want to remind you, it's not too late for you to post a question if you haven't already. We do have several to go over and not so much time, but feel free to post your questions even now. And so right now I'll begin reading through the question and answer questions posed, and the panel will answer them. And I hope we'll have some great discussion. So I'm pulling up the questions now. So the first question is from an anonymous attendee. They're asking what caused the rapid spread of COVID? And I think Maria had already touched on this briefly. Does anyone want to just briefly go into that?
So I'll add to it then. Really, what we know about this disease is that it spreads really quickly in close contact, so in congregate settings. It spread very quickly in the beginning because we were not identifying all of the people who were ill and who really had disease. There is asymptomatic spread, as you've heard before. Others may want to add to that.
I think that was a good synopsis of how we've gotten to the situation that we're in and how we're ending up in the second wave here. There's some talk about, fatigue from having the restrictions and easing up on the restrictions and what we know is effective with masking and social distancing and being close. So we do know that those are the main ways that this spreads. Okay, so I'm going to move on to another question. Okay. So from President Dragovich, is there evidence of transmission in college classrooms when masks and 6-foot distancing are consistently used and properly employed? This is to Maria.
So the question was about, is there evidence if proper distancing is used in class that limits the spread of disease? Is that what the question was?
If there's evidence that with a mask, wearing masks and the social distancing of 6 feet, that there's transmission in college classrooms. Is there any evidence that that is occurring?
I'm not aware of any studies that I could point to, the qualitative gold studies, but I am aware of a lot of spread in college campuses, and much of what I am familiar with is more spread in off-campus or outside of the classroom situations. In other words, gatherings of groups of people, social types of gatherings. That's where many of the cases that I've seen have identified as spread. But we have quarantined classes where there have been cases that are positive. Again, because we know of that close contact, that it's droplet spread, and it does spread rather easily. But I cannot point to any study that's definitive on that.
Thank you. Another question we have relating for Maria, and I guess we could extend this to the whole panel if you have some commentary to add, but what interventions do you feel that student nurses may implement to further flatten the curve?
I think for student nurses, I really think that you need to learn and understand about what droplet spread means, understand the correct use of PPE given the situation. If it's outside of a healthcare environment, we're talking about social distancing and regular masks. That's different from when you're in a hospital or clinical environment. Really understand infection control practices and quality assurance. I go back to that all of the time. Those two things, understanding infection control and looking at quality assurance, I think are very, very important nursing practices. Perhaps Allison in her study has other comments?
Yeah, I would suggest, one of the things I would suggest is having, one of the things we've done here is we've gotten our students involved in, actually early on when there wasn't enough PPE, we had our students involved in preparing some of the face shields, and so we got them active and engaged in the process of helping to do the prevention work, right? How do you prevent the spread? And I would also encourage students to see it as an opportunity for them to share their knowledge of disease and disease spread and what are the mitigating factors. What can you do? You encourage people to wash their hands. You encourage people to wear a mask in public because, you know, there was a study recently done in Kansas, just published a handful of days ago, where they showed that counties that followed the statewide mask mandate versus counties that didn't follow a statewide mask mandate. And indeed, you want to flatten the curve, you use a mask, because the studies absolutely clearly showed that in the counties where the mask mandate was implemented, the curve went like this. In the counties where they didn't implement the mask mandate, it went like this, and it's rising still. So if you want to help flatten the curve, encourage people to wear masks, because the evidence is very clear, very, very clear, that wearing masks in public will stop the spread of the disease.
That's great. I also wanted to add that here at Hartwick, we've been encouraged, some of our nursing students, all of the seniors, in fact, and by the end of the year, will have completed the contact tracing education through the CDC. And, you know, just sharing that knowledge, better understanding what goes into that. And I think that really provides something else to share. And taking that preventative approach is going to help in flattening the curve. So great question and great answers from everyone. Let me move. We have a lot of questions. This is a really great discussion. So let me continue through the discussion. Okay, so we have a question from a senior nursing student, Alexis Hillman. She said, many people argue that schools should be closed. How do you feel about decisions made to reopen many facilities that closed at the beginning of COVID-19 in regards to the spread of COVID-19 and public health? I guess this is to the whole panel.
Which schools are we talking about? Universities or all schools? That's my question, but I'll address. It's really tricky. There are ways to open schools. I think I don't know, and maybe Maria will have some other ideas. But understanding what are the particular risk factors in a specific area you know, a national, I don't know that it's necessary to say all schools should be closed nationally. I think there may be some areas where schools can be safely opened with certain procedures and precautions taken into account, as long as those are followed. Other areas, it's just too dangerous to open schools, right? And so they should stay closed. So it really depends on the nature of the environment you're in. You can't take things out of the context of the environment. So I think that's a really important factor to consider.
Other
I
factors.
have to agree with that. Go ahead, Chris.
I would say another factor is the ripple effect of closing a school and shutting it down completely. You have tertiary effects to the folks that are the providers for the kids at home, the ability to provide for them, come for them, and care for them. They may not be able to take a day off of work or 6 months off of work to be able to provide care for their 6, 7, 8, 9, 10-year-old kids. So it is a big challenge that I agree needs to be addressed in specific locations and areas and can't be a one-size-fits-all determination. Sort of goes back to my logistics points earlier. It's all about the logistics of managing that action.
Great points. Maria, did you have anything else to add? I know there was a moment where.
I was just going to agree with everything that Allison and Chris has said. It's not a one size fit all. There are different rates of disease in different parts of our state even, and we need to be aware of that and help people address the fear. The fear is very, very real. It causes stress, and we need to help address that with some facts and supportive behaviors.
That's a great point. I think all of you summarized that issue quite well. I'm going to kind of shift gears here. I think there were some questions for Chris. He sort of answered them in text, but I think it'd be good for everyone to hear some of your answered. And so I'm going to kind of synthesize two of the questions. So one question was asking, what were some of the failures and successes of with handling COVID-19 in your field? I guess that kind of is asked a couple of times in this thread. So if you could speak to that.
Yeah, I prefer to look at them as challenges and opportunities versus failures and successes. The challenges were breaking that mold and thinking differently, getting our staff to the places that we needed them to be to do new jobs. I mean, we had folks that trained up to become contact tracers and spent some intense time learning how to do that. We had folks that had to learn the incident command system so they could come and be members of the emergency support functions that work out of the State Emergency Operations Center and know how to run the state's New York Response computer program. So these just-in-time challenges and training opportunities to get into that flow of the ever-evolving state response, and it needs to continue to evolve, and I think we've been pretty nimble and flexible with it. One of the bigger challenges is the long-term impact. We at Parks are being asked to kind of fill a dual-fold role. We serve as a very, very necessary and critical mental health break. People can come to a beautiful park, relax in nature, bring their dogs with them, and just decompress and de-stress in some really positive ways. That's really tough. Our organization, while it's relatively large, relies on a lot of seasonal employees that go away during when school starts back up and colleges start back up. And so keeping the park operational while at the same time managing being the driver at the Ferry Street Logistics Distribution Center or the incident commander for the Glen Island test site can be a real challenge, or managing the entire Jones Beach testing site and hosting that at our park. Those can be real challenges to try to keep that long-term support both for the new mission and your traditional mission going. Hope that answered the question.
Thanks, Chris. I think you did a great job answering the questions. I kind of wanted to talk a little, there's some questions that are asking about, let me pull it up here, asking about how we're going to manage the logistic shift to preparation for administering vaccines from testing. So would anyone on the panel like to speak about what that's going to look like, or some of the actions that are being taken now? So in terms of delivery, when the vaccine is ready, I know Chris talked a bit about that, Maria as well.
So I'll start and then maybe others want to chime in, but the logistics behind delivering the vaccine are huge. The states, all of the states, including New York, have already submitted plans to the federal government. New York's draft first version of our vaccination plan is available on the DOH website. It's very long. There's a lot of pieces to this particular vaccine. There are a number of different vaccines in development. We don't know exactly which one will be made available to us in New York. There's some very specific details regarding cold chain management for the vaccine. Some of the vaccines that are being developed require extremely cold temperatures for storage prior to use. And not that equipment is not available to every place, but we do have identified facilities across the state that have that kind of capacity. So we're really looking at developing the plan. I would say all county health departments, providers, facilities have in the past developed and provided vaccine, usually flu vaccine or immunizations. And so there's a structure that can be built upon for that. The testing sites are a very important model to look at because, as Chris has alluded, we've tested large numbers of people in those testing sites, much more than you would do in a single provider office or through a pharmacy. And so those models are things that we need to look at. And we are looking at those very things and putting together plans.
And from our smaller perspective on that, in Parks, we've been working to identify staff members that have leadership skills and experience that can provide support in the management of these sites, such as they can serve as the logistics chief for a location, or they can serve as a deputy operations chief for a location and help that location manage and run itself and support itself versus, we're not docs and we don't play one on TV. So we don't have that expertise, but we sure can manage a lot of people coming to a facility and flow them through and flow them out, because that's what we do every single day in our normal job. So we're trying to translate that, pre-identify staff, and be prepared to support our state partners in health as directed. And we're trying to be nimble early.
Thank you all for elaborating on that. It's great to hear that there is an infrastructure in place and that there are plans going forward. It's a really complex issue. I kind of want to change gears again because we have so many topics to talk about and there are so many great questions. We have over 30 questions here, and we are not going to have time to get to all of them by the time this is over. So I want to just switch to discussing some of the topics on mental health. We had a great question from Professor Turk Gibson. She asked, Dr. Holman, are researchers looking into the impact of COVID on children in relation to adverse childhood events and the impact on their long-term health?
I believe there is some research being done in this area. I'm assuming you mean in terms of like already having had prior life trauma. That's something that I'm doing, not in terms of children, but yes, there is work being done on children, but it's not as much research on that in that area as there is on adults at this point. There are a lot of people trying to understand not just the mental health of the children, but also the the logistics of the spread of disease among children. So it's a much, working with children, doing these kinds of studies with children is a little bit more complicated than doing it with adults. And so it's not as simple or as easy to get into the field in that population. But yes, I'm going to guess that, I'll remember the name and I'll put it in the chat. there's some researchers in Oklahoma that have been doing a lot of work on collective trauma in children, and I'm going to bet that they've got some work going on it. So that's not, unfortunately, I don't do work specifically on children.
Thank you, Dr. Holman. It's an interesting topic to consider because we know of all of the literature that we have on, adverse childhood events. So how do these, collective traumas impact children for life is something to really consider. So
I can say, if I may, I can say that, there's a powerful evidence that's been demonstrated across in the stress and coping literature for decades, demonstrating the role of adverse life events in physical health problems down the road. And so, especially in younger children. So when children experience major life events, child abuse, domestic violence of any sort, whatever it might be, those kinds of adverse events can actually, and separation from your family, those kinds of things can very much lead to not just mental health problems down the road, but also serious physical health ailments. Some fantastic studies have been done on whole population samples in parts of Europe demonstrating this. And it's a very well-known phenomenon, and I'm sure that it's complicating kids' reactions to the pandemic. And we're seeing young people, and when I talk about young people, I mean like late teens and 20s, who are, the rates of depression and suicidality have gone up. And, we've got young people are at the greatest risk right now. And I think it's really important that we do everything we can to try to protect them and target our interventions toward these populations that are really in need. And that would be young people, Black and brown communities, people at highest risk, the communities that are at the highest risk.
Dr. Holman, thank you for emphasizing the importance of really targeting the vulnerable and those vulnerable groups. That's really an important take-home message that everyone needs to know, and that's just so important. We don't have much time left. We're almost out of time, and there are so many more questions. So my apologies if I didn't get to your questions. There were so many, but I wanted to just bring it back to the panel and just ask you, what would you say is your main take-home point? What do you want everyone to know from this presentation and going forward about COVID-19 pandemic?
I'll jump in and lead off. I would say, despite it's going to be a long time, be positive and be flexible. We have done so much in such a short period of time, and I think we tend to forget about that sometimes from the constantly looking at the increasing death figures. But if you take a look at what we've done to move stuff through the system, to get test kits created, built, put together, sent out, back, tested, we went from being happy if we could get a couple thousand done in the state a day to 100,000 in the state a day. So we've built some tremendous success, and remember that and continue to build off that. We are very, very good at what we do, even when we don't know it.
So from my perspective, I really would encourage people to take personal and protective protections, okay, to minimize your risk, to be very, very key here. You know what to do, the right thing. It's not always easy to wear the mask in social situations. It's not always easy to do the right thing, even though we know what it is. Don't go to work sick. Talk to each other, talk to your families, but really protect yourselves so that you can care for others. Really use good infection control. And the last thing that I'll mention is I believe everybody should learn incident command, something that Chris has alluded to. You can look it up. It's a very, very important system to become familiar with.
There's even one geared specifically to hospitals.
Right.
Okay, I think it's my turn then. I would say, I would encourage you to remember that this is a major collective event that we're walking through, and that mental health challenges are going to be there for everybody at some level, in some way. We're all dealing with a different kind of stress, but it's important to pay attention to and recognize when you see somebody who you may think their behavior is a little odd. Ask yourself the question before you judge. Ask yourself the question, what might they be dealing with right now? We're all in this major pandemic. We're all in this really horrible situation dealing with this pandemic. And everybody's got their stress and trauma, you know, everybody's got that. And so having a place of compassion in our hearts when we see other people and we think some of their behavior might not be appropriate or whatever, I think it's important to have that compassion. Try to talk to people if you want to encourage them to wear a mask or encourage them to hand wash. Be gentle, be kind. But my message is mental health problems are normal in a situation like this. It's not that somebody's abnormal, and don't look at them that way. Just recognize that this is a normal response to a really messed up situation, and that the more compassion we have for each other and the more we focus on getting their needs, addressing the needs of the most vulnerable people in the society, the better off we will all be.
Thank you all so much for participating in this panel. So thank you, panelists. Thank you, community. Thank you to our donors and everyone for participating in this session. I think we've learned a lot here today on this really important topic. I think we had a great discussion, even much more discussion than I thought we would have. I wanted to just end with some sort of thoughtful sentiments kind of from our panelists on this COVID-19 pandemic. I just wanted to reaffirm the notion that this is a marathon and emphasize the importance of long-term commitment and compliance with the public health initiatives to keep the campus and community safe and thriving. Through diligence, persistence, and self-care, we can all have a positive influence on the trajectory of this pandemic. So once again, thank you all. And I hope you enjoyed this lecture and that you'll consider attending our Spring O'Connor Chair lecture. I want to leave you with just one statement: stay safe, and remember, you can all make a difference going forward.